And welcome to the second day of Academy of Oral Surgery virtual meeting. This is our spring meeting. Today we have with us one of the powerhouses of dentistry, Dr. Frank Zastro. Dr. Frank Zastro is by all means, he does not need any introduction. He's an oral surgeon. He's an international speaker. He's the founder of the international Facebook group, The Real Bone Builder. And that's a platform with more than thousands of dentists worldwide, and basically focuses on biological bone augmentation. And I've seen some of these works, and they're amazing, Dr. Zastro. It's an honor to have you with us.
Thanks so much for a kind invitation.
Perfect. So some housekeeping material here I would like to share. You guys can see my screen, right? Today we're going to have 5 world-class speakers. We're starting with Dr. Zastro, and I would like all our colleagues to join us and earn the CE units here. We can earn the CE units, 5 CE units, and this is we'll show you how the link how to get those basically CE points for you. And also for whoever is not a member, we are offering a special promotion to become a member, again, for first years for free. And we're so excited to announce that we just had this past month, we had over 500 new members joining our Academy of Oral Surgery. So we're very proud of that. Also, we are starting back with our International Extraction Academy workshops, again, hands-on. So very exciting. We used to have at least dozens of these, around the country before COVID-19, and we're excited to announce that we're coming back. And we have some specials that I'll share with you guys again. But with all means, Dr. Zastro, it's an honor to have you. We're excited to hear your presentation. Thank you.
So thanks first for a kind invitation and introduction, Kayvan. It's always my pleasure to be here on this prestigious platform. Also, thanks so much to Kian Oshar. And so from my side, I'm ready. We can go into the topic, hot topic, I would say, the importance of soft tissue management in vertical augmentation. And I think we will jump now right into my presentation. And I hope you can see it right now on the screen. Wonderful, perfect. So like some of you know already, the last 12 weeks or 12 years, I'm working purely in our clinic with autogenous bone, and according to the biological bone augmentation concept, the split bone technique of my former mentor, Professor Fuad Khoury. And the topic today, soft tissue augmentation, and it's always a symbiosis between hard and soft tissue management. So the time is limited, that's why we can only stay slightly on the surface, but I want to give as much information as possible. So we will start with the possibility to go for crestal incision. We will cover the semilunar tunnel approach, and finally the probably most advanced technique, the tunnel approach, according to Khoury. And I don't want to bore you with my CV. We said some words which is maybe interesting. If you want to know more later after this presentation, just go on our new website, myimplantbusiness.com, and get there some more information. At the end of this presentation, I also have a little present only for you this time. Before, I was traveling a lot. I built this Facebook group, Real Bone Bearers, with meanwhile more than 15,000 doctors worldwide. And like you see here, I'm really missing the time when I had in person courses and lecture, and hopefully soon we will be there then again, and hopefully I will meet some of you then. So let's jump into the first approach, which is the crestal incision, and later we have to correct also the situation with the apical reposition flap. What do I mean with that? You see here the situation before. So we did here a sinus floor elevation, bone augmentation. You see on the left side, everything looks fine. But sometimes you see the patient with a worse situation again. She was a smoker, and after 5 years, you see the horizontal bone loss and also vertical bone loss in that area. So failed sinus elevation after 5 years. So explantation was needed, and we did then the re-augmentation with the so-called parallel technique. And you see here on the right side, the probing already more than 10 millimeter deep pockets, which showed also the bone loss here in this situation. And you see the inflammation going on. And the problem probably was that the bone substitutes didn't integrate due to the not good regeneration potential at this patient. And you see after 5 years, when we took out the bone substitutes, it looked almost like the day before. So totally no integration because of a very poor regeneration potential. And this is always the risk when you're working with non-osteoinductive material, which we usually prefer. So now we are actually standing in the situation that we are having a lateral and a vertical defect we have to overcome. The regeneration potential in this area is even worse. And you see here already, we were working with blades according to the split bone technique of Professor Curry, where I was senior physician then for almost 4 years. And we are fixing these plates then on distance. You know these techniques already. If not, please feel welcome to join our Instagram profile. You find me on Dr. Frank Sestro, and join us there and see many hundreds of wonderful cases from also many colleagues meanwhile and former students. So we really started a movement in the last years, and more and more real bone builders, how we call ourselves, are starting with these techniques and have really wonderful results. And we don't have to hide our results. Probably that makes this technique standing out to all the other techniques when we do the re-entry, because this is then real bone and not like we know it from many other materials and techniques that we have to remove a big part of it again, or it's not integrated at all. So this is the situation. You see the plates, and these are filled with vital bone chips, and after only 3 to 4 months, so we do not have to wait longer than this, we have already, you see it here, wonderful red bone, and we can go here for the implant placement. We are placing then the implants, usually slightly subcrestally. You see a nice regeneration of the whole area. And you see here the redoing of the situation after it failed in the first trial due to the use of bone substitutes. And after the healing of the implants, we have now a very flat vestibule. Actually, we have a mobile mucosa around the implants, and this is always important after doing big bone augmentation. Doesn't matter if we did GBR or BBA, like we call it, biological bone augmentation with the split bone technique of Professor Curry. We have to correct in many times this mobile mucosa to fixed mucosa again. And we have a wonderful technique for doing this, which is in the maxilla, the apical reposition flap. So we are just shifting the keratinized mucosa from the palate then to the buccal side, like you see it here. And you see we leave the periosteum on the bone. This is very important, and this will heal over secondary wound healing. And usually then after another 3 weeks, we have wonderful results. You see here the nice thick keratinized mucosa on the buccal side, and whenever the patient is now eating, speaking, laughing, there is no movement around, and this is really, let's say, one of the secrets for a long-term stable result. The first is having vital bone around the implant shoulder, and the second secret is having fixed or keratinized mucosa. So like I said before, hard and soft tissue are always as in symbiosis and going together. So we can do a Crestel approach, like I've showed it you in the former case. Now, in those cases, when we are in the maxilla and when we have a thick gingiva phenotype. In some cases, we have to also thicken the tissue in advance. We can do this, for example, with a CTG or with a palatal pedicle flap. Of course, in these 45 minutes, we cannot go through all techniques, but in the end, when you say this is interesting for you, I have something for you prepared. Now we are going into the second technique, which is the semilunar tunnel approach. We are using this actually in most of the cases when we are going for vertical augmentation. The advantage to Crestel incision is that the incision is not laying above the augmentation area, because if we do a big bone augmentation, what happens from time to time, we don't want to have all the pressure underneath. So that's why we are laying our incision into the vestibule. That's why it calls semilunar tunnel approach, like a C-shape approach into the vestibule. And I want to show you the situation here. We have here some bone loss. Also, it was a referred case. The situation before, after removal of the tooth, which had the bone loss, and the implant, which also had the bone loss. Here once more, the clinical situation before. We have a vertical defect, and you see already also mobile mucosa around the implants, but we are correcting this at the very end. So we are not correcting the mobile mucosa in the beginning, we do this in the very end. And you see here already the vertical defect we have. It's a vertical inside the contour defect, because we have bone peaks on both sides, which is always a good thing, because we have here support on for our bone plates. We used here the right angle technique, one plate, a roof plate occlusally, and later one plate to the buccal side. So we have two ways how we go vertically. It's the parallel technique and the right angle technique. Again, too short time to go here in detail through all techniques, but I want to show you as much as possible. And this is the semilunar tunnel approach, starting 1.5 centimeter from the middle of the crest into the vestibule, going then partially split flap to the crest, and then opening full flap. And you see here harvesting the bone from the retromolar area. I know many of you are still scared, which is slightly paradox, because most of us, or actually all, especially oral surgeons, are trained in taking a removal of wisdom teeth, right? Even if they're deeply impacted. So we are destroying actually most, or maybe every day, the retromolar area for getting the tooth from there. But when it comes to just harvesting or collecting the bone, suddenly many of us are still scared and think this is invasive, or the patient doesn't want it. But let me tell you one thing, it's probably one of the biggest take-home messages. It's only in our head. It's not the patient who is not wanting something. It's because we might not that comfortable with that. But trust me, you can do it. It's not a big thing. You can start just with a small block. I will also give you in the end a free ebook where we show on 30 pages how to do step-by-step the bone harvesting part, that you can really feel safe. And you see here also some principles. So we are staying actually away from the ramus. We are not going for ramus graft, though it's said sometimes, but actually we are going for the a block in the retromolar area. And you see here the incision design. They always have to cross the lines. Then we can do the perforations on the crestal side. We are staying away from the ramus. What you see here is the danger zone. And you see here in which area. Only in the danger zone you can theoretically come close to the nerve. But again, all this is described then in our free ebook. I will give you the link at the very end, so stay with us. And after splitting the block into the plates, after collecting then also the chips, we are going now for, it's a little bit like making arts. We are working with a template. What you see here, we want to give our template the right shape. It's also very important to remove all sharp edges extraorally. So don't do this intraorally, because the more you are manipulating the plates than intraorally, the higher the risk that you're also making the plate loose after fixation with the screws. So we want to reduce the risk as much as possible. And you see, you can feel, you can tactile feel with your finger that it's all nicely rounded. And this is important to avoid any perforation or exposure of the plates. And you see here we are fixing then these plates. First, the occlusal plate on distance. We are filling the gap then with the chips, like you have seen it in the case before. Actually, it's a quite simple concept when you understood first the rules. It's like the chips are like water. They are going in every niche. So it's not that time consuming like we knew it from the past with the full cortical blocks, which have to be everywhere in touch with the residual bone. And still the results were not that good, because it took too long time that the block is revascularized, and usually you have then a lot of bone loss due to the bone resorption. So with a split bone technique, you're splitting it, you're working with these plates, placing them on distance, and filling the gaps with chips. You have really perfect results. What is the idea of the chips? It's enlarging the surface for the blood vessels. So that means you have much faster blood supply, much faster nutrition, and revascularization. And the plates are actually only for giving the stability to this situation. So don't use afterwards a membrane. So this is absolutely wrong. It's absolutely also understandable for those who are coming from GBR, which are probably most of you. I also was trained in GBR, but the principles to work with the BBA concept, so or biological bone augmentation, split bone technique, and then working with the plates is totally different. So you don't need to make here any or to work here with membranes. You can save the money. All the money also for bone substitutes and the membranes and everything. Actually, there is no need for that. Only the only invest you have is the little screws, and the rest is actually, you can also charge for the whole procedure, and the money doesn't go to the industry, it goes into your pocket, which is also maybe for some of you interesting. So never forget also to remove all sharp edges. Like I said, remove them as much as possibly extraorally, but after placing those plates together, there is always a small edge existing. And you see with the round diamond burr and good irrigation, this is also crucial. Always use a lot irrigation whenever you are working with autogenous bone. So whenever you work with the bone, you need good irrigation, or whenever you store, for example, your plates or your chips, or even when you're scraping them with a bone scraper, you should always use a lot of irrigation or put them into saline. So it should never be dry. And afterwards, we have a very section. You see the incision is not now above the bone augmentation, so but it's more to the vestibule, and you see it's super tension free when you are following this concept, which we do here with the Semilunar tunnel approach. You see super tension free. It's a 2-layer closure. First, we are suturing periosteum to periosteum after doing a deep dissection of the periosteum, and then we are going mucosa to mucosa. And we have really a very, very high success rate, close to 98%, even in vertical cases. So it's really a very safe approach. And in this case, we had a little bit more scar tissue. This is not regularly the case. But again, I don't want to show you only the showcases. And you see here on the left side, after the implant placement, how it looks like. But of course, I know you're curious. You want to see how it looks intraorally or clinically. I would also want to see it. And you see here, it's real bone. You see the vascularized bone. You see the blood vessels in the bone. But also here, now look carefully. I can also stop here maybe for a second. I want to show you also here in the mesial area, there was a little bit of bone loss on the lingual side. And we always want to have a perfect result. So this is our ambition. And this is how I was trained when I was at Professor Curie. And you see here on the linguals or on the palatal side, there's a little bit bone missing, but this is not a problem for a real bone builder. So you're going for the tuberosity, you're taking here because there's a surplus of bone, a little bit of the bone. And here with another screw, you can quite easily fix it here again, remove a little bit the sharp edges, and afterwards you have really the perfect result. And the gaps you can fill a little bit with the bone chips. And this is all made with pure vital bone, pure autogenous bone, nothing artificial or from cow or from dead human body or whatever. So it's not only the good results you're giving to your patient, but it's also the money you're saving. And let's say when you calculate 250 euro maybe for one bone augmentation with the GBR, like I was used to do it with the bone substitutes, maybe one can 150, maybe another 100 for the membrane 250, and this maybe only twice per week. I know many of you are doing bone augmentation every day. So, but let's say just twice per week would be 2,000 in a month and would be almost 25,000 per year. And you can now really calculate how much you're saving over the years. And I can really say I saved millions over the last more than 10 years. And here you see the situation before. You see on the left side the situation after. Still, maybe 1 millimeter could be augmented more, but I think still a nice result. And so this patient was sent back to the referring doctor. But before, I told you already, maybe I just make it here a little stop. We did again the apical reposition flap. So it's really a standard technique, which is quite important to correct the vestibule, so the mucogingival border, because like I said before, whenever the patient is eating, speaking, laughing, it has to be fixed. If there is mobile mucosa around the implant, you will have a problem. And after maybe 5 years, when the evil periimplantitis is coming, this is really not periimplantitis. Actually, this is dentist-made periimplantitis or self-made, because we might have forgotten to correct the vestibule, or we might have used the wrong materials, maybe only substitutes, and the implant shoulder is covered with artificial substitutes. But like I said, the first secret is we need vital bone around the implant shoulder. And don't worry, what you see here, the open area is healing then via secondary wound healing. And again, just look on my Instagram account, Dr. Frank Sester. You will see now really hundreds of cases like that. Just today I shared, or yesterday, 4 cases also from colleagues, wonderful cases where they do the parallel technique, vertical cases. So there is really no limit, and it's all for free. And this is the situation after, and we are giving our patients a real safe result by working with pure autogenous bone. And you see here a recent study, or almost recent, from 2019, a 10-year follow-up after vertical augmentation, because some people say, or more the industry, you have to use our whatever bone substitutes because autogenous bone is not so stable. It's my favorite sentence is it's shrinking or melting like snow in the sun, which is of course not the truth. Everybody who is working with autogenous bone with this new technology, not talking about the full cortical blocks, and you see here the results after 10 years, less than 1 millimeter bone resorption, and we are talking about vertical bone augmentation. In lateral bone augmentation, the results are even more stable. So don't be scared of these techniques. They are proven and they are strong, and to become a real bone builder, and there is no way around, go for these techniques. So one more case, tunnel approach. So this is actually a more advanced technique, because you have seen already in the Semilunar tunnel approach, you are having less good overview, because it's actually the incision is made in the vestibule, while in the tunnel approach we are working with only relieving incision, 2 vertical relieving incision, And yeah, my also good friends and colleagues, Juan Lara and Jose Mombel, they are also doing fantastic cases in Instagram about the tunnel approach. To be honest, I'm a little bit more fan of the semilunar tunnel approach you've seen in the last case, because it gives me slightly a more better overview, and I always want to see what I'm doing, and still I'm not having, like in the Crestle approach, the incision above the bone augmentation. So I think this is a good compromise. But anyway, I still want to show you now the approach. And this was a 64-year-old female patient with vertical defect in right mandible. So planned was now also to go for the right angle technique. The right angle means one plate occlusally, one plate on the buccal side. Then why not on the lingual side? Because there is no muscle activity, or hardly any muscle activity. So that's why you don't need to place any plates on the lingual side, and we are going here for the tunnel approach or tunnel technique. And you see here already the mouth floor, how the mouth floor is actually going into that space where you have the vertical defect. And of course, you could also place now an implant deeper, but that would be hard to clean properly, especially if it's an inside the contour vertical defect. All these differentiations between inside and outside the contour defect, and the exact approaches and techniques. For those of you who are interested, I have something for you in the very end. And you see here the approach of the retromolar area, because in the maxilla, it's enough to have only one vertical relieving incision, but in the mandible, it makes sense to have also a second vertical relieving incision, like you are seeing it here in the distal area, because we want to harvest the bone from here. So this also makes it slightly easier, because we can do the preparation from both sides. And we're also not going straight into the vestibule like you are seeing it here, but also in a semilunar shape or in a C shape, so half moon shape. This is the idea how we are doing this. And you see here the harvesting of the block after doing the 4 incision. There are different ways you can do this with piezosurgery. You can also do this with a micro saw, which is coming back actually to the market this summer. And you have here your block, and we are working afterwards then not with a full cortical block, like I said. We are actually splitting it. That's why it's called split bone technique, according to Curry, into 2 thin bone plates, and we are scraping it then with a bone scraper. And because we need not only the plates, we also need enough particles to fill then the space. And those of you who are already in love with the bone scraper, and usually when I ask during my courses who's in love with the bone scraper, all are actually raising the hand. But I will tell you one thing: you will be much more in love when you're using actually the bone scraper extraorally, because when you're scraping on these blocks or on these plates, it's not like in the mouth where the full or actually jaw of the patient is moving, but extraorally it's totally rigid and nothing is moving, and the amount of bone chips you can collect from there is much bigger. You see here already the amount we harvested. And what we are doing now, again, I just go back, is we are working with a template. This is very important, because whenever you're working with this tunneling technique, or I can also call it modified tunneling technique, what is the topic of today. The topic was soft tissue augmentation when it comes to vertical augmentation. Then we have to work with templates. It's much easier then to transfer this shape then to the bone block, and to give it the right shape. And after giving it the right shape, don't forget also to remove the sharp edges. And what I did here now is I'm making a little bit like art. I'm bringing the the plate into the right shape. And when I cut it, I only cut it 90%, and the last 10% I'm actually breaking. This has the advantage that this small piece is not flying away. This would be the flying bone technique, what we don't want. Just cut it 90% and break the rest, like you see it here. All small details, but like in every technique, the devil is in the detail. And you see, I chose here the distal incision to slide in the bone plate, the occlusal bone plate. So we are always starting with the occlusal bone plate, and it's very important. I have to stop here always to give you a little bit more details. It's very important to place this plate also in the correct manner. So it should not be angled slightly to the lingual side or to the buccal side, because then you're creating actually a sharp edge, and this can cause a perforation or an exposure, what you don't want to have. So ensure that your occlusal plate is really placed parallel to the occlusal plate, that you don't have this problem. And you see, you can fix now your plates through the relieving incision with one screw maybe in the mesial part, one in the distal part. You see here the gap you are creating. This gap is again filled then with the bone chips, and you see before the mouth floor was actually going into that defect, and now it's the new level. And you see this huge amount of bone chips, and the block we harvested here was actually not even a big one. So some of you who are already following our Real Bone Builders Facebook group or following me on Instagram, you know already that sometimes we are collecting much bigger blocks, and still this huge amount we collected just from this medium-sized block. And imagine now also again how much money you're saving, because otherwise you had to pay a lot for these bone substitutes, which are actually are more expensive than gold. I would say I think it's around 3 times the price, or sometimes even more than gold. Can you imagine that for half a gram? So this can go into your pocket than into somebody's else. And also in those times we have to think a little bit economically. And that's why when we can work with the patient's own bone, we can do that. We should do that. And you see here the right angle technique, one plate occlusally, one plate now on the buccal side, and in the very end, which we only have to suture now the relieving incision. You see in the crestal area, no incision. That means the periosteum is intact here, which also gives a much higher success rate. But of course, this is an advanced case for really advanced real bone bearers, not the case how it should start. You see the nice new bone level here, and the 4 screws, which are actually enough. But if you're hesitating, or you're not 100% sure that it's 100% stable, just use a second or a third screw maybe for a plate. And you see here the screws. If you have a thin gingiva phenotype, this was not because of resorption. You see it here, no resorption. But sometimes when you have a thin gingiva phenotype, then you have to thicken it later on, for example, with a free gingival graft or with a connective tissue graft. We all know the wonderful studies, zero bone loss concepts of my good friend and colleague, Thomas Linkevicius. So if you don't know his book yet, I definitely recommend it. And on the right side, what you see here is especially in the mesial area, we did the vertical bone augmentation, and it's not mineralized yet. So the mineralization takes maybe another 1 year that it looks on the X-ray, same like the residual bone, but still this is stable, especially when you're placing your implants here inside, because we all know we have to give here functional training for the bone. So, and I sent also this patient back to the referring doctor. After we did here the so-called Cassandra vasiboblasty, it's an alternative to the free gingival graft. I'm a big fan of free gingival graft, but this is a nice alternative. Unfortunately, also here, not enough time to go through all techniques in detail, but the Cassandra vasiboblasty is actually the an alternative, like we are having the apical reposition flap in the maxilla, we love to use the Cassandra and vasiboblasty in the mandible. And overall in our concept, we have only 6 techniques to handle all these situations, +2, 6 + 2. And the 2 techniques are actually the semilunar tunnel approach when it comes to vertical, and the tunnel approach, which I also showed you now. So you see this typical scar tissue after the Cassandra and vasiboblasty. So in the end, it's very easy to make here just a small incision and put the healing abutments on it. And this is how we send then the patient back. And you see the bone level, the mineralization looks already much better just 3 months later. But now have a very close look to the next X-ray when we did a control picture after half a year. And what you see here now is an osteolysis, so some bone loss on the distal implant. Actually not there where we did the bone augmentation, but distally from it. Anybody of you have an idea where this should come from? So I was just citing Thomas Linkevicius, and I think you all know his famous studies from, actually cement remnants. And this was exactly the case. The referring doctor, unfortunately, so we prefer screw-retained restorations. He does it with cement retained. And when we explored that area, we saw all the cement remnants, which we removed then. And after a few more months, we did another X-ray, and you see it recovered. So it looked actually now quite good again. And I want to cite in this context also another study from Thomas et al. 2009. And this is actually, I think, quite interesting, that in 70% of the implants with a perimplantitis and cement access, this healed after cement removal. So while usually the chances of recovery after, let's say, a normal perimplantitis are quite hard. So when it only comes from surplus of cement or excess after removal, it can recover in 70% of the case. Always keep that in mind. And still, I would also recommend you to go better for screw-retained restorations that you do not even have this problem. This also, one of the take-home messages of Thomas Linkevicius. And we are coming already to a conclusion. So hard and soft tissue augmentation, these were the words I was also starting with, are always in symbiosis. So what I showed you today was actually the tunnel approach and also the semilunar tunnel approach, and both are recommended in vertical defects in mandible and maxilla, especially when we have severe cases. Like I said, when we have this C-shape or this half-moon incision, like in the semilunar tunnel approach, we don't have all the pressure underneath the incision, which would be the case when we would go for a crestal incision. And you see here the next point, we can use also crestal approach or crestal incision, but then we should have only medium-sized vertical defect. So I would not do this when we have a big vertical defect, and we also do it only in the maxilla. Why only in the maxilla, not in the mandible? Because the muscle activity is much less in the maxilla than in the mandible, where we all know we have the muscle masseter and a lot of muscle activity here. And additionally, they should also be a thick gingiva phenotype. And if we don't have a thick gingiva phenotype, we can change it to a thick gingiva phenotype by doing, for example, a palatal pedicled flap. It's like a pedicled connective tissue flap from the palate, or a CTG, a connective tissue graft. Both is possible. And for example, when you go for explantation or extraction, always keep that in mind, that you can combine this already with some soft tissue augmentation. Of all, probably for those of you who are just starting with this topic, a little bit overwhelming, maybe a surplus of information, but still I hope you could take some ideas from it. The last point I showed you here today, the apical reposition flap and the Cassandra and vasiboblasty, because in those techniques, it always, especially when you go for big augmentation, it comes together with a flattening of the vestibule, and we are actually getting the tissue for closure from the vestibule, which leads then to a more flat vestibule, and also sometimes mobile mucosa, which has to be corrected in the very end. Always remember, first secret, you need vital bone around your implants. Second secret, you need keratinized or fixed mucosa in the para-implant area. And finally, I promised it to you in the very beginning, for those of you who want to become experts in biological bone augmentation, learn more about the split bone technique, I have something for you, a free ebook. So for this, you just have to go on our platform, myimplantbusiness.com, and check it out. You just go, then everybody of you know this nice gentleman. Just go here on free media. You get it for free. Just fill in the form. And for those of you who want to have it also in your hand, who want to get the print version, you can also go here to our shop and look just for manual. It costs, I think, 19 euros, so also not so expensive. But then you have the printed version. And for those of you who say, finally, after this presentation, wow, this topic interests me, I want to become an expert in this field of biological bone augmentation, then please check out our masterclasses. Watch the videos, go here just on the button masterclasses, and fill in the form, and my team will reach out for you, and we will tell you more about our programs. And I think I'm right in time. Thanks so much once more that I had the chance to be on your prestigious platform, on the Global Summit podcast platform, and the Spring Festival. And I think when we still have time now for Q&A.
Sure. Dr. Zastra, thank you so much. What a wonderful presentation. Very informative. I follow you, and I see your cases, and they're amazing, honestly. And anybody who's been doing grafting or implant dentistry, of course, is familiar with the fact that autogenous bone is always your best option, and I know you follow that principle, and that's amazing. And thank you so much for all the beautiful cases you and also I saw that you shared some basically failures. We had bone loss, or we had so that's I think the most important thing, to know what to do when we have those things. Otherwise, anyone can place an implant, but what do you do when you have an issue? So but we appreciate that. That's where we learn, right? Complications and issues when we do this type of surgeries. But thank you so much. We appreciate you sharing all this information with us. So if you didn't have an option, Dr. Zastra, if you didn't have an option, this is my question for you, that to use an autogenous bone, what would be your second best option choice? If let's say you don't have an option, you can't do it, say, or you're in a situation where say time is limited, what would you choose? Use xenograft, or will you use an allograft?
I would use any bone substitutes. For me, they are quite similar. They are just fillers, osteoconductive and not osteoinductive. If I would have a situation where we have an inside the contour defect, so like a sinus, or a defect where we have a lot of bone walls from where the regeneration comes from, I would go for maybe any bone substitutes. Nothing, to be honest, in particular. I mean, for sinus, we are using actually also bone substitutes. Because this is a very good indication for using bone substitutes, we are using there is a so-called a layering technique. That means we are putting it, we are not mixing it. We are putting one layer of autogenous bone and one layer of bone substitutes, because I mean, it would be an over treatment if you would go for a sinus, for example, for the retromolar area, to go for a block. So this wouldn't be, I think it would be a little bit too much. Oh. So, but we don't have muscle activity here, and we have, when we do it correctly, we expose, we denudate all the bone walls from where the regeneration comes from. So bone substitutes are a very good option here. And if it's genogenic or allogenic or whatever, so to me, they are quite similar. But in the moment when it comes to to an outside the contour defect. Let's say we have a thin crest and we want to build bone horizontally or vertically, actually. In those cases, I would not trust any pure osteoconductive material, because there is no impulse or no signal from these substitutes to the bone to grow out of the envelope. Why should the bone do that? It's totally against all natural thinking. And we know that those people who are actually good, also colleagues and friends of mine, who are having fantastic results with GBR. So, but for getting these results, they have to harvest actually a huge amount of autogenous bone chips, maybe not the plates, but they're going for the same big amount of bone, usually also from the retromolar area, like I do. Whatever it is, if it's the sausage technique or something. So they're harvesting the full retromolar area, the full external oblique line to come to these results. And maybe then there's a percentage of maybe 30% of bone substitutes. Then there, I don't know why, but in my opinion, this is not necessary.
I see. Great. No, absolutely. No, and we appreciate you being here, Dr. Zastrow. Very informative seminar, and I would love to. We're following you on your the Real Bone Builder platform that you have, and we're very proud to have you as a part of our region at the Academy of Oral Surgery. And we appreciate your support.
Thanks so much. I also appreciate so much, and it's really an honor to me, to give also my part to your fantastic platform. I mean, what you're reaching now, how many 10,000s of people you're reaching. This is amazing. Especially also to Keanu Shar and you, what you created here. So fantastic.
You. And you know, we share the same goal basically. And I see, you know, most of your and you were saying like that the education that you're giving most of is for free, basically, and we're pretty much doing the same thing. We're just trying to share and educate people, and kind of and that's our goal as well. So
that's the way how to do it. Exactly. You have to give first, and this is really. And I think that the old way of teaching was a little bit, I give you a little bit, and the rest you have to get in the very expensive course or something. But I think it changed today. Nowadays, you have to give a lot, and only then when your students are successful, then when they really succeed, you can grow with them together.
Absolutely. I agree with you 100%. Well, thank you very much, Dr. Zastrow. You know, so we do have a chat here on the side, and you know, if you get a chance, if there's other questions, if you can check later on today to respond to the questions, we would really appreciate that. And I'm just going to go back and share my screen one more time and go over some of this flyers that we have. About I'm sorry, I'm trying to reach this out. So we do have our International Extraction Academy hands-on workshops coming back on. You know, we're very excited about that. You know, there is a special code. You guys can use the AOS 2021, and you'll get a amazing 50% off that course. We used to have a dozen of this, and because of COVID, we kind of cut down. So we're bringing them back with our brilliant Dr. Widerman and Dr. Carlos Morao. So you guys will be learning a lot of good information and about extractions and grafting and all that. Also, I really recommend, you know, whoever is not a member yet, to become a member of the Academy of Oral Surgery. We just had about 500 new members joining our academy last month. So this is a free offer for the first year. I'm also very happy to announce that our fellowship and mastership you know, they're you know, you're gonna have to be a member to obviously apply for those, and you know, we're about to announce those shortly. And again today, we have the 4 more speakers, world-class speakers for you guys. Again, thank you so much, Dr. Zastro, for your beautiful presentation. And we'll see you guys. I appreciate you, all the colleagues who are watching this and are with us today. And we'll continue in a little bit. So please stay tuned. Thank you.